dear colleagues. Today I'm going to speak about cardiac resynchronization therapy. Who is the best candidate? Fortunately, Yahya talked about it. Who are the patients candidate for cardiac resynchronization therapy, but I'm going to go over the evidence behind that. I have no disclosure, but I'm happy to receive money from anyone who wants to give. Cardiac resynchronization therapy is associated with significant structural changes in the heart, improvement in the function of the heart, and significant functional improvement. This is reflected on the two hard endpoints: reduction in hospitalization and decrease in mortality rate. So if all these benefits we see in patients in heart failure, why we don't offer this therapy for every patient with heart failure? Let's take a brief history about this 68-year-old male patient who is known to have congestive heart failure. He was referred to us for device implant. His history is important for ischemic heart disease. He had a history of non-ST elevation MI 2012 and CABG. He had COPD. He was in functional class 3. His echocardiogram showed dilated left ventricle ejection fraction less than 30%, had moderate to severe tricuspid valve regurg, moderate pulmonary hypertension. He was on optimal medical therapy for a long time. His ECG showed sinus rhythm with intraventricular conduction delay, and the QRS duration 122 milliseconds. The referring physician told the patient exactly these words, and these are the words from the mouth of the patient. The one with the 3 wires, and he means CRT, may make you feel better. And if not, no harm done. We would like to see if that is true or not. Who is the best candidate? This is the summary of the answer. Best candidate is class 1A from the guidelines, irrespective of if these guidelines are coming from the heart failure group or these coming from the arrhythmia teams or any guidelines, Europeans, American, Canadians, all of it say the same. Any patient with congestive heart failure, systolic heart failure, ejection fraction less than 35%, class 2 to 4, he's in sinus rhythm, left bundle branch block morphology. If the QRS duration is more than 150 milliseconds and on optimal medical therapy for at least 3 months, and his life expectancy is more than 1 year, this is the best candidate. But we would like to have patients like these patients who have a super response to CRT. And we define super response when they have more than 15% improvement in the ejection fraction. Why this group of patients is important? Because if you look at the analysis of this study, you see that, and this has been reproducible, that super responders have significantly less probability of heart failure or death compared to usual responders or the non-responders. And the same regarding the death. The super responders have significantly less probability of death. And again, even for ventricular tachyarrhythmia, the super responders have significantly less. So we would like to know these patients. Most of the predictors from many trials showed the same. Females have a better chance of responding and being super responders. If the QRS duration is more than 150 milliseconds, morphology of the QRS is left bundle, the body mass index is less than 30, which is contrary to what we know about heart failure. No previous myocardial infarction, in other words, non-ischemic cardiomyopathy, and left atrial volume index is smaller. Let's see the evidence. In women, cardiac resynchronization therapy do better. These are some of the observations that we have seen in the literature. Usually, females are underrepresented in the clinical trials, but very important to notice that females have typically higher rate of non-ischemic cardiomyopathy, and we know this is a predictor of response to CRT. They have higher left bundle branch block morphology, and this is again, true left bundle branch block is a predictor of response. And they have higher procedure complication which is a reason why they are not referred for CRT implantation. On the other hand, they have lower rates of atrial fibrillation, which we know is a reason for non-response to CRT. They have lower rates of ischemic heart failure, which is a reason for non-response. And in general, they have smaller LV volumes. And this is reflected on the outcome. So we see regarding the survivals, female has a better survival chance compared to males. And there was missing a slide here. Even in patients with relatively narrow QRS complex and left bundle branch block morphology, you see that female patients have significantly better outcome regarding heart failure or death when they are compared to males. So males do not benefit, while females do benefit a lot regarding death or heart failure. So in conclusion, regarding this specific point, women do benefit, specifically when they have left bundle branch block morphology, and even the QRS duration is narrow. What about the morphology of the QRS and the duration? In many studies, and this is from the MADE IT CRT trial, showing that patients with left bundle branch block morphology, they do better when they receive CRT, not ICD. And this was for all subcategories of patients. To take this a step further in RAFT trial, this is the first trial that in mild heart failure, there was significant survival benefit. And if you see patients with left bundle branch block, they have higher chance of living and less mortality compared to the other group. When we look at all patients with non-left bundle branch block morphology, we see there is no difference, irrespective if it was right bundle branch block or non-specific intraventricular conduction delay. Regarding the QRS duration, many meta-analyses and small studies were conducted, but these are two large meta-analyses were published and showing the same findings exactly, that when the QRS duration is more than 150 milliseconds, no doubt that there is significant benefit. But if the QRS duration is less than 150 milliseconds, there is no benefit from CRT. We talked about the morphology alone. We talked about the QRS duration alone. What about the combination of QRS morphology and duration together? This has been studied from Dr. Burney group in Ottawa, and they found the following in the RAFT trial. Patients with left bundle branch block, irrespective of the QRS duration, there is a linear correlation, which means all patients with left bundle branch block morphology, they will benefit from CRT. But the broader the QRS complex, the more the benefit. On the other hand, patients with non-left bundle branch block, they do benefit if the QRS duration is wider. And this is reflected here and seen here. The cutoff was almost 160 milliseconds. If the morphology is non-left bundle branch block, there is some benefit. On the other hand, if it is less than 100 milliseconds, there is a trend toward increase overall mortality from CRT. Before we leave the slide, you should notice that the benefit was starting very late, after 2 years of implantation, this divergent. And if you look at the numbers are small. For that reason, we can't draw conclusion from this that patients with non-left bundle branch block and broad QRS duration, we can't say that they benefit a lot from CRT. So what are the clinical implications of that? In patients with left bundle branch block, the broader the QRS, the greater the benefit. There is no benefit in CRT for patients with non-left bundle branch block, especially when the QRS duration is less than 160. Now that was about patients with indication for CRT, and the QRS duration was more than 130. What if it is less than 130? As Dr. Yahya said, there are about 35% of patients with narrow QRS complex. They have echocardiographic evidence of dysynchrony. For that reason, a prospective randomized trial was conducted in patients with narrow QRS complex and systolic heart failure. It is called echo-CRT. And the result were not surprising. Patients with narrow QRS complex do not benefit from CRT. But the most important finding in this trial is actually this. The overall mortality was higher among patients with narrow QRS. So please don't send your patients when they have narrow QRS complex for CRT implant. Later on, a meta-analysis just recently published in Europace talking about all the prospective randomized trial for patients with systolic heart failure, ejection fraction, as you see, all of them less than 35%, half of them ischemic cardiomyopathy, NYHA functional class 2 to 4, CRT on versus CRT off, and the QRS duration, all of them less than 130. And the results were not surprising. Regarding the heart failure-related mortality, there is no benefit. Regarding the heart failure hospitalization, no benefit. But the most interesting that all-cause mortality was again increased. So to conclude this point, CRT in narrow QRS complex do not reduce heart failure mortality, does not reduce heart failure hospitalization, and associated with higher overall mortality. Now back to our patient who was said by his doctor that if no benefit, no harm. That was not our opinion, so we implanted a single chamber and a single coil ICD. Now, we know that some of the patients do benefit a lot from CRT, but despite our optimal selection, we still have many patients who do not respond. Why? Because there are some of the factors that we know play a role in that. Potential reasons for non-response usually suboptimal lead placement. When we put the LV lead, we put it in the wrong vein or the vein that is not appropriate for the patient. Failure of LV lead capture, sometimes atrial fibrillation with rapid ventricular response, lack of viable myocardium, and we have seen in the morning, MRI can help in that, suboptimal AV or VV delays, and sometimes latency in the LV stimulation or capture. Let's take this case. JJ is a 43-year-old male patient. He's known to have ischemic cardiomyopathy with severe LV dysfunction on optimal medical therapy for 2 years. His NYHA functional class was a 3 with a frequent hospitalization for optimizing his medical therapy. He was referred for CRT-D implant. The patient was declined, by the way, for VAD. This is his baseline ECG. As you see, it is ischemic ECG. There is intraventricular conduction delay. This is not a typical left bundle branch block morphology. Fortunately, anatomy was suitable, and we implanted the CRT. And look at this fantastic ECG. QRS duration went down from 150 milliseconds to less than 90 milliseconds. It was 88 milliseconds. Narrow QRS complex, nice. There is an R wave in V1, V2. There is a Q wave in 1 AVL. We said by the end of the procedure, while this is the patient who's going to benefit, but unfortunately, he's a non-responder. He was readmitted again and again and again. He did not respond. So we did an echocardiogram follow-up for him, and this is what we found. Ejection fraction did not improve. Most interesting that the left ventricle diastolic function is suggestive of restrictive filling pattern. Is this important? Well, it looks yes. So for that reason, we have some recent and novel predictors of non-response to CRT. We'll go over them. One of them is this study which looked at the acute improvement in the ventricular relaxation as a predictor of response for CRT, and they found that acute improvement in diastolic function, it predicts reverse remodeling and response to CRT. Just recently published in Journal of Echocardiography, this study which showed the restrictive filling pattern exactly as in our patient at 1 week after CRT was independent predictor of mortality and hospitalization. It means these patients need optimization of their medical therapy rather than device. We studied about 300 patients included in this analysis. We included about 200 patients, and we found one of the novel markers that our patients with a pre-existing tricuspid valve regurg, if they have moderate to severe, they have significantly worse outcome. And this is reflected directly on the hardest endpoint, on mortality. Whether is this a cause of their mortality or a marker, we don't know still yet. But we know that patients with severe tricuspid valve regurg at baseline, they don't benefit from CRT. Another important analysis was done, and we have noticed that during implantation of the right ventricle lead, sometimes we have increased the tricuspid regurg. And this is exactly what we have noticed, that among patients who have TR deterioration, there was significant non-response. Their response rate was less than 40% compared to patients who did not have any tricuspid valve regurg. Let's take this brief case. She's a 56-year-old female patient diagnosed as non-ischemic cardiomyopathy. Her ECG showed sinus rhythm with left bundle branch block at 163. She was on optimal medical therapy. 3 months later, she was referred for CRTD implant because of non-response. 1 month post-implant, she suffered from multiple ICD shocks. These were associated with worsening heart failure. Her ECG showed sinus rhythm, proper biventricular pacing. Her echo showed improvement in the ejection fraction from 25% to 35%. But despite this improvement, her functional class declined. And device interrogation showed normal electrical parameters completely, multiple appropriate ICD shocks, and complete heart block. At this stage, we scratched our mind. What's going on? Number one, non-ischemic cardiomyopathy. 2, the patient had ventricular tachycardia recurrent. She had worsening heart failure, and in a relatively young patient, there is complete heart block. Our suspicion was in place, so we did PET for this case, and we diagnosed her as sarcoidosis. So sarcoidosis, something that usually don't respond to CRT. We analyzed in Ottawa Heart Institute patients with cardiac sarcoidosis who presented to us and underwent implantation of CRT, and we found these 2 interesting findings. The first, that these patients, if you implant CRT for them, they do benefit from the implantation. Structural-wise, the myocardium might recover. However, the clinical benefit is small. Why they don't benefit? Because they may have the systemic illness that they have can affect their clinical status, or the lung involvement, or something else, or even deterioration of the LV function per se. Another case of a 58-year-old female patient with non-ischemic cardiomyopathy for 8 months, ejection fraction less than 30%, NYHA functional class 3. She was on optimal medical therapy. She was referred for CRT. Unfortunately, very poor cardiac venous anatomy. For that reason, she was referred for epicardial lead. This is her baseline ECG, which showing left bundle branch block morphology, QRS duration 144 millisecond. And after implantation of the CRT epicardial lead, you see there is a Q wave in 1 AVL. But most interesting to notice that the chest leads did not differ. So I said, there's something wrong here. Where did they put the lead? And this is exactly the problem. The problem that the lead was implanted in the apical region and anteriorly. In other words, this is suboptimal location of the LV lead. Is this mentioned in the literature? In detail, actually. It was studied in the literature. From reverse trial, made it CRT, and it was very clear that among patients, if you implant the lead in the apical location, then look, the mortality, heart failure are significantly more than the non-apical. The same for the reverse trial, where they showed significant increased mortality in apical location. So what we learned, if you want to send your patient to a surgeon, tell him exactly where to put the lead. To conclude, response to CRT is different. Patients who benefit more from CRT, who have wider QRS duration, left bundle branch block morphology, and female patients with non-ischemic cardiomyopathy. On the other spectrum of patients with narrow QRS complex and non-left bundle branch block, they usually don't benefit from CRT. Thank you for your attention.
Thank you very much. Gives me a great